Well, welcome everyone, and thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. Quick footnote, I have been on active surveillance since 2009, and I'm still a member of my local support group that got me started on this journey in the first place. Our purpose here is to educate individuals about options regarding AS, which is not a treatment, but a management plan. I would like to remind everyone that we are not anti-treatment, we are anti-unnecessary treatment. So, we are not here to dispense with any medical advice. Nothing said during these meetings by our speakers, ASPI, or the audience should take the place of your consultations with your medical professionals. We are going to hold all questions until after the speaker's presentation. You can submit questions in the chat box, which we will try to address. Please keep your questions limited in scope. Our speakers do not have the time to review your case history. At that time, you can also click the raise hand button from the bottom of the Zoom window toolbar, and if there's time, we'll try to call on you. During the meeting, please keep yourself muted. The speakers presenting here today are generously donating their time, so we want to be respectful of that. This meeting is being recorded and will be available on our website in approximately 1 week, and you'll get an email notifying you when it's ready. Also, if you subscribe to our YouTube channel, you'll automatically be notified when a new video is posted. I'll quickly add that ASPI is always looking for volunteers, so if you have some time and talent to help spread the AS word, please get in contact with us. We also appreciate your donations, no matter how small, no matter how large the amount. If you can share, please go to our website on the donate page. So without further ado, we'll have a few quick words from our chairman, Mark Lichty, who will then turn the meeting over to Howard Wolinsky, the organizer of this meeting, to introduce our guests. So relax, enjoy the meeting, and I hope you leave a little bit small, a little bit smarter. Okay, take it away, Howard. Or take it away, Mark. Sorry.
Mark, yeah, Mark. Okay, good morning, all of you, and thank you so much for coming to this meeting. Active Surveillance Patients International has been on the leading edge of promoting active surveillance, promoting less overtreatment, less biopsies, trying to do our best to help you men navigate this sometimes complicated world of active surveillance. And I wanted to express my personal appreciation to the three doctors that we have with us here today. We don't have the funds to pay them. They donate their time, and we really deeply appreciate that. I would remind you that we're going to stick around for afterwards. We used to just end the meeting after the webinar was over, but we found that men were hanging around looking for a support group, and so we just kept going. And so the meeting will end about one. The formal meeting will end about 1:30, but you're all invited to stay with us and with our support group afterwards too. I did want to remind you too that we have searchable short films. So if you have an issue and you go to our website, you'll see the searchable short films. You can put your issue in, and you'll get a 1 minute tidbit of addressing the issue that you're concerned with. And as far as we know, there's no other organization that has anything equivalent to that. Um, with that, I'll end and introduce Howard Wolinsky, our intrepid program chair.
Well, good morning, everybody, from Des Moines, Iowa. Today, for me, heading to a memorial service tomorrow for Ken Mason, who many of you probably knew. He didn't die from prostate cancer, but he did die. And so we're having a memorial for him in Lincoln, Nebraska. At any rate, just a short bit of history. A few of us had started ASPI around 2017, 2018. And one of our key issues was gadolinium. A lot of men were worried about deposition of gadolinium, rare earth metal in the brain and what that could do. They were concerned about short-term effects of it. And Mark and I helped another group, ANCAN, start the first support group in North America aimed only at patients with low-risk prostate cancer. And Mark and I took a lot of ribbing because almost every week we were talking about gadolinium. Well, apparently the doctors were listening, or they came to their own conclusions and started looking for ways to either reduce the dose of gadolinium, or it turns out to eliminate gadolinium altogether. And that's what we're here to talk about today. We have three really important speakers in this field. First off, we'll have Professor Veeru Kasivisvanathan. I hope I said that right. He's an academic urologist at University College London and consultant surgeon at University College London Hospital, specializing in prostate and bladder cancer research. His studies have transformed prostate cancer diagnostics through pioneering use of MRI, particularly via the landmark Precision and Prime trials. And Prime trials are going to be Prime today. Dr. Matt Davenport, MD, MBA. I don't know where the MBA fits in, but we'll find out maybe. He's at the University of Michigan, and all of you know, every time I mention the University of Michigan, I say go blue, because I'm a little, well, I was a journalist in residence at the University of Michigan. Dr. Davenport is a professor of radiology and urology at Michigan. He's recognized for his research on safety, efficacy, and quality of radiologic imaging, particularly the use of intravenous contrast materials, which is what we're talking about here. His investigations address contrast-induced kidney injury, gadolinium-based agent safety, and optimization of prostate, and I don't know how to, let's see, hepatobiliary MRI protocols. We're talking about livers, folks. He's chairman of the College of Radiology's Committee on Drugs and Contrast Media, and he's led national policy efforts on imaging quality and patient safety. Finally, we have Dr. Ben Pockros. I wrote an article about their work at Michigan for Medscape, and the editor didn't believe me that Ben is a urology resident. You know, he just you know, but he's a resident, but he's forward thinking. He also has an MBA, so we have a little bit of a pattern here. Don't know what it means other than the economics of this. And he's at the University of Michigan, go blue, and his work spans prostate cancer imaging and the economics of oncology care. One of his colleagues there, Dr. Morgan, said that Ben basically championed the effort at Michigan to introduce contrast-free MRIs. And so that's why he's here. This is our panel. I think we'll start off with Veeru, then we'll pass it over to Matt, and then we'll hear from Ben. And so after that, well, we had a big panel, so I apologize. I went on and on. But Veeru, why don't you take it over?
Thanks, Howard, and it's a great honor to be here speaking to all of you today. and I'm going to give you a talk about the study, the PRIME study, which is a recently published study in the area looking at whether we can avoid gadolinium contrast. So I've got some slides that I'll share with you. Hopefully you can see those slides. So thanks for the introduction, Howard. So you can probably tell from the accent, I'm based in the UK. That's where I practice as a urologist, and it's the center through which I coordinate most of my research at UCL. So multiparametric MRI, which is the MRI with gadolinium contrast, is now the standard of care diagnostic test for men with suspected prostate cancer based on a raised PSA. And many studies, including the Precision study, confirm this and have led to guideline change over the last 5 years. Now, in publishing some of these works, we actually created a problem in that not every man who needed this MRI could actually get one. And in the UK, I'd say we're actually doing okay, but still, when we started the study, only 62% of men who needed a prostate MRI were actually getting one. And I know data from the US in the last few years has shown that around a third of men who need the MRI are getting one with suspected prostate cancer. So I think it's fair to say there's still a little bit of work to be done on allowing every man who needs a scan to get one. So we wanted to try and address that problem. And if we look at what makes up the multiparametric MRI and compare that to the MRI without contrast, we can try and figure out how we might do that. So the multiparametric MRI is a 30 to 40 minute scan. It has 3 parts: the diffusion weighted images, which looks at how water molecules move through the material; T2 weighted images, which give you a good idea about the anatomy of the prostate; and contrast enhanced images, which is where you inject your gadolinium contrast and you take some images at time intervals and you look to see whether an area enhances with the contrast, which shows up as a bright area, for example, where there is cancer. And with the contrast injection, of course, you have to have a person around who is available in case of a contrast allergy reaction. The patient needs to have an injection and the scan takes a bit longer. If you take out the contrast injection, you get what we called is a biparametric MRI, which avoids that cannulation and the need for the doctor, the gadolinium contrast, and results in a shorter and cheaper scan. And you're using the diffusion weighted images and the T2 weighted images alone. So prior to the PRIME study, there were studies that had looked at whether or not we could avoid contrast. Some of these had some limitations, for example, smaller studies or just done in one center. And it's fair to say that of the types of the parts of the MRI, the contrast sequence usually is the least well done of them all. And so many of the previous studies hadn't really tried to make the contrast part of the scan really good to see whether it could add anything when they evaluated whether or not it did add anything. So we wanted to try and change that with the PRIME study. So we designed this international study, which is a diagnostic, it's called a diagnostic yield study, and it looks at patients who receive the bi and the multiparametric MRI reads. And this is a high-level study, so it's almost the top level of evidence you could have for a study investigating this. And the aim was to assess whether the shortened biparametric MRI was as good as the longer, more detailed multiparametric MRI in detecting what we termed was clinically significant cancer, which is based on what you see under the microscope when the prostate biopsies are analyzed. So the idea in this study was looking at men from 22 international centers who underwent the full multiparametric MRI. The person reporting the scan was first blinded to the contrast sequences. So they only had the diffusion and the T2 weighted sequences, and they had to produce a report. Only when they submitted that report could they then get access to the contrast sequences. When they then had the contrast sequences, they submitted a second report containing information from all of the sequences. And if either the first report or the second report were suspicious for cancer, did patients go on to have a biopsy with biopsies, which we call targeted biopsies, to the areas on the MRI which look suspicious. And this was a study that we carried out across 12 countries, 22 sites. You'll see there's representation in the US, in Europe, and Asia as well. So we enrolled over 500 patients, and their average age was around 65, and the PSA of around 5.6. So these are patients who it's the first time they've been referred for suspected prostate cancer, and this is a typical population in this type of setting. And when we look at what was used in this study, because this is important when we think about how applicable the findings are in the study to the average center, we can see the majority of scanners were what we call 3T scanners. Generally speaking, in the majority of centers, there'll either be a 1.5 or a 3T scanner, which is the magnet strength of the MRI scanner. And 3T tends to be a bit newer and a bit more powerful. 1.5T tends to be a bit older, but it doesn't necessarily correspond to better image quality if you have a more powerful magnet. But generally speaking, the study had slightly newer 3T scanners in the whole. Biopsies were done via a mixture of the transrectal approach and transperineal approach. And the way that the biopsies were targeted was done by a variety of approaches. On the whole, it was done with what we call fusion biopsy, which is where you use software to help you use the MRI information to find out where you're going to place your biopsies, as opposed to cognitive biopsy, which is where you try and figure it out in your head based on the MRI scan. So initially we thought prior to the study, if we don't use contrast, the radiologists might have less information to go by, and therefore they might be more uncertain as to whether or not there'll be any suspicious areas. So we thought by using a biparametric approach, more men would be recommended to have a biopsy. But we actually didn't find this. You can see that there's a similar proportion of patients recommended to have a biopsy, whether it was biparametric or multiparametric MRI. Now, the contrast-specific areas did identify new areas of suspicion in 31 out of the 490 cases. And most of those were new areas that weren't seen on the biparametric MRI. And around a third were existing areas which were bigger when the contrast was revealed. And for our primary outcome of clinically significant cancer detection, which we defined as Gleason 3+4 or higher, this was very similar for both multi and biparametric MRI at around 29%, which allowed us to conclude that, in fact, the biparametric MRI was very similar to the multiparametric MRI for significant cancer diagnosis, without increasing the number of men who would be recommended for a biopsy. We also have different ways of looking at how good a test is, and one of those is describing the test performance characteristics. And we can do that by talking about the test sensitivity, specificity, positive and negative predictive values. And in summary, there wasn't really a difference between the biparametric and multiparametric MRI for the test performance characteristics. And one of the things we really wanted to do was think about, if we did drop contrast, how would that influence what treatment options patient might be offered and how you might do those treatments. So we carried out a central multidisciplinary team meeting with a range of different specialties who would diagnose and treat patients with prostate cancer. They reviewed the biparametric MRI with the biopsy information from the biparametric biopsies, and they made treatment eligibility decisions. So we decided, would this patient be suitable for surgery? radiotherapy, focal therapy, or any other treatments. And we also then planned how we would do that treatment. For example, if it was surgery, whether we would spare nerves on one side of the prostate or the other or both. We did the same thing for the other treatment modalities. We then unblinded the whole team to the contrast information, and they reconsidered their decisions on which treatment options a patient would be eligible for and how they deliver those treatments. And we wanted to see how often it changed when you had the contrast information. So when we had the contrast information, it made a difference to treatment eligibility in 4% of cases and how you deliver a treatment in 3% of cases. So overall, there is a small impact, but I would say minimal on how treatment decisions are made or treatments are delivered. And one of the things that's really important to understand from the study is how does it relate to other centers? And I think one thing that's important to take home from this study was that the central quality control, where at the end of the study, we looked at all the scans that were done and we evaluated how good they were on this 1 to 5 scale of quality, where 5 is the best quality and 1 is the worst quality. And we found that 70% of the scans were the best quality, i.e. a score of 5. And that allowed us to make this conclusion that the scans in this study were of good quality. And because we did optimize the scan quality beforehand, it's probably what we expected. And the contrast, importantly, was of good quality in this study. Most of the time there were issues with quality, it was due to the other sequences, not the contrast. So we achieved what we wanted to do in giving contrast the best chance of showing a difference in this study. So to summarize the main findings, the biparametric MRI without contrast in the presence of good quality scans resulted in no difference in clinically important or unimportant cancer detection, no increase in biopsy recommendations, no difference in test performance characteristics, and minor differences in treatment eligibility decisions and treatment planning. And so we concluded that amongst experienced radiologists with good quality scans, biparametric MRI without contrast enhancement should become the new standard of care for prostate cancer diagnosis in the primary diagnostic setting, which will hopefully increase the accessibility, cost effectiveness, and adoption of prostate MRI and allow us to achieve our goal of every man who needs a scan being able to get one. And there was a big group who helped to develop this study with representation from around the world, to whom I'm very grateful. Without their hard work, especially peri-COVID, it wouldn't have been possible to deliver the study. It was a labor of love over around 6 years, so thank you to them. And we do have a more detailed podcast, if anyone's interested, which is on GU Cast, which is available via YouTube and Spotify and other platforms, where we discuss critically some of the findings. And I'm really pleased. It's been published now for just over a month, and it's received quite a lot of attention, obviously indicating that it's an article that people are interested in. Thank you very much.
Thank you, Veeru. Certainly, we're interested. This affects all of our lives as patients on active surveillance. So now we're going to move over to Dr. Davenport. Are you ready?
Yep, absolutely.
So tell us all about gadolinium, and were we crying wolf 10 years ago when we were so worried about it?
Sure, I'll do my best. So I chose not to do slides just to keep it more casual and colloquial. And obviously, if you have questions as I'm talking, please do post them in the chat and I'll respond to them in real time. So gadolinium, as was mentioned earlier, is a rare earth heavy metal. And if it's by itself, it's actually toxic to your body. So if someone was to inject raw gadolinium into your body, it would be toxic. And so the way that pharmaceutical companies get around that problem is they attach the gadolinium to something called a chelate. That chelate binds strongly to the gadolinium and prevents it from interacting with tissue. And if we look at patients who have received gadolinium-based contrast over the last 20 or 30 years, it really does have an exceptionally good safety profile. The times in which the safety profile breaks down are when the gadolinium breaks away from the chelate and starts to interact in a free way with the rest of the tissue in your body. That happens more frequently with older contrast agents and in patients who have severe kidney disease. So let's say if you're on dialysis or if your kidneys are really not working very well and one of the older agents is used, that's where you have the biggest risk from gadolinium because that gadolinium can break away from the chelate and start interacting with tissue. In patients who are using modern gadolinium contrast agents, and they have normal or near normal kidney function, that risk is almost zero. The other risk from contrast of any kind is that some patients might get an allergic reaction to it. That's also rare. And if we look at severe reactions to gadolinium-based contrast, it's on the order of 1 in a million patients might have a really life-threatening reaction to contrast. It's pretty uncommon. The other risk of gadolinium is something called gadolinium retention. And what that means is even if the gadolinium is not interacting with your tissue in that harmful way I described before, sometimes the gadolinium-based contrast can stay in your body for longer than you might want it to. It could stay in your body for sometimes months. Sometimes that gadolinium can be retained in tissue. So, for example, there's a bunch of studies showing gadolinium being retained in parts of the brain. Now, when that gadolinium is retained, if we look at the cells and see what's happening to those cells, there tends to be no evidence of injury happening. This was actually looked at by the FDA in the late 2010s, the US Food and Drug Administration, and on the totality of the evidence, found that there was no scientific evidence of harm, but made an acknowledgement that it was happening and started putting a label on gadolinium contrast indicating that this can occur. So the three things we've talked about are free gadolinium interacting with tissue, resulting in fibrosis and negative condition called nephrogenic systemic fibrosis. That pretty much, we don't see that too much anymore. I mean, that's a pretty rare thing to happen nowadays using modern contrast agents and patients who do not have severe kidney dysfunction. We talked about reactions, and a reaction to gadolinium, allergic reaction to gadolinium is pretty uncommon, and a severe reaction is really uncommon. And then gadolinium retention. There's different kinds of contrast agents. Some of them are more stable than others, but in general, the gadolinium retention that I've described doesn't seem to be associated with measurable harm, at least in a scientific way. There's some other considerations when we give gadolinium. So, after it's injected into you, obviously at some point it has to come out. So you'll, for example, urinate the gadolinium and it can go into your toilet, then you flush your toilet and it goes somewhere, sewer, so on. And if we were to measure in wastewater plants, you can actually detect gadolinium in the wastewater plants. So this is a lot of studies in Europe have shown this where basically downstream of medical centers, you have a higher concentration of gadolinium in the wastewater supply. Again, does that cause harm? It's not been measured to cause harm so far, but it's something people are aware of and have been studying it. Some other issues around gadolinium are more practical. So if you go to the doctor and you get gadolinium-based contrast, it requires, as Veeru said, someone to put an IV in. That IV can have some pain or discomfort associated with it. And then there's the cost of buying the gadolinium-based contrast and using it, and then the infrastructure involved. So there has to be someone to put the IV cannula in, and then someone to monitor in case there's a reaction. Veeru said that sometimes that's a doctor. In the States, it could be a doctor or a physician assistant or nurse practitioner. Someone has to monitor that contrast. So it's kind of logistics. In addition, when you go to get your MRI, if you do have contrast, it makes your appointment a little longer because someone has to show up a little bit earlier to get that gadolinium, that catheter placed, and a little bit longer of scan time while you're having those images acquired with contrast. So it creates an access problem. And as Veeru pointed out, the number of people who qualify or it's a good idea to get a prostate MRI in, we're not really 100% of those people aren't actually getting one. So the goal of trying to increase access by making the scan slot shorter and less expensive is a shared goal that we all have. So those are kind of on the the negative side or the harm side from the contrast itself. Well, what on the positive side? Why are we doing this at all? Most MRIs that you would get for most indications do include contrast material. And the main reason why is because it does, as a general statement, I'm putting prostate aside for a second. As a general rule, it highlights normal from abnormal, or it indicates things where abnormal might be occurring. So if there's an inflammation or if there is a cancer or something, the contrast can make it more obvious or easy to see. So that's why people tend to give it, is because it improves the ability to make a diagnosis. And what Veeru and his team have done is to say, well, in this narrow context of prostate MRI, we're trying to figure out, is it important to do a biopsy or not, or detect an important cancer or not? Is that contrast really necessary for this indication, which is a very important question. And as Veeru mentioned, there's three major sequences that radiologists use to try and make a diagnosis with an MRI. There's the diffusion weighted imaging, which is basically movement of water molecules, which is, I would say, probably arguably the most important sequence that we use. T2 weighted imaging, which is looking at anatomy. And then historically, this dynamic contrast enhanced sequence, which uses the gadolinium. Now, one of the key points of the PRIME study is that before the PRIME study was kicked off, there was an effort that was underway to make sure the image quality was good. And this is really important. I want to emphasize this. There was effort that was taken by the clinical teams to make sure the image quality was good. The reason why that was a necessary step was not only to make sure that the study was done appropriately and you can believe the outcome, but also to make sure that the other sequences weren't impaired in some way. So a lot of radiologists use that post-contrast imaging, that gadolinium sequence, as a backup when the diffusion-weighted sequence is messed up for some reason. And if there's not a lot of image quality improvement done on the front end, that diffusion-weighted sequence, which is really so important, might be messed up. It could be messed up if there's some rectal gas, like if sorry for the crude language, but if a patient needs to fart and hasn't done that, that gas in the rectum can actually make the diffusion-weighted scan not look very good. There was another comment in the chat about what if you have a hip arthroplasty? Well, that metal that's in the area can make the diffusion-weighted sequence not as good. All of this is to say that the diffusion-weighted sequence is really important, and when it's impaired in some way from like rectal gas or metal that might be nearby, many radiologists use that post-contrast sequence as a backup to make sure that nothing is missed. So making sure the image quality is good is really important. For radiologists that maybe don't have as much skill, or maybe they're newer at it, or maybe they're more of a generalist radiologist, they might be using that contrast sequence as a backup to them. So that's kind of the long and short of it. The advantage side is trying to improve diagnostic accuracy. The downside are some of the things I mentioned, like gadolinium retention and this rare risk of the gadolinium interacting with your tissues and the rare risk of a reaction, some of this wastewater contamination, cost, logistics. And what Veeru's team has shown, in my opinion, pretty compellingly, is that if the image quality is good and the people who are reading your scan know what they're doing, in most cases, you can remove the contrast and do so with a good amount of confidence that you're not going to miss too much and the patient's going to get the right treatment. And that's very reassuring, because if you take that contrast away, you end up saving, you sort of completely eliminate all the potential costs, logistics, and harms that I described, and you mostly preserve that diagnostic accuracy function. Now, if you're in a situation where the person reading your scan maybe is a little bit less qualified, or it's a place that's maybe doesn't have as good of image quality, then there's a little bit of an asterisk next to it. And in that asterisk, we're not exactly sure, are we getting the same outcome or not? And that's something we cannot at this time easily speak to. There's a few comments that have come into the chat that are specifically related to gadolinium, so I'll do my best to try to address them. The first is, in the bottom here, it says, any risk of CNS damage from gadolinium? And probably what Raj is talking about is when we have gadolinium retention, where gadolinium is we kind of see it in brain tissue after getting administered, is that causing harm? And when we look at a histopathologic level and look at that gadolinium that's been retained, I'm not referring now to NSF, I'm referring to the gadolinium retention phenomenon, there does not seem to be any injury. from that gadolinium retention. And when the FDA reviewed this in the late 2010s, they came to the same conclusion I'm describing, which is there's no scientific evidence of harm, but it is occurring. So it's listed as a label for all gadolinium-based contrast media that gadolinium retention, including in the brain, occurs. But so far, there's no scientific evidence that harm is happening. Jim has asked a question about pacemakers and gadolinium, and there's really no relationship or concern between having a pacemaker and receiving gadolinium-based contrast. The issue that comes up with pacemakers has to do with, can you get an MRI at all? And yes is the short answer, but it's complicated. So at my practice, for example, if someone has a pacemaker, they go through a screening process that involves a cardiac electrophysiologist to evaluate the safety of that device and the reason the scan's being done and make a risk-benefit decision about it. And oftentimes we do scan patients who have pacemakers, but it's complicated and has more strings attached to it. But the gadolinium itself doesn't really impact the pacemaker. How might a patient know if there is or should be an asterisk associated with a scan or its interpretation? And that is the million-dollar question, Steve. And the short answer is it's not easy to tell. As a general rule, one recommendation I might have is to go to a place that has a reputation for excellence and quality. And sometimes you can find that out by looking online or talking to friends and sort of look at what places are notable or respected in your area. I think that'd probably be the best way to do it. But one of the, at least in the United States, one of the sad realities is that knowing which places deliver on great quality is very reputational and not very data driven. It's hard to know sometimes which places are best. So my advice would be, in your area, go to the place that has like a 5-star rating for quality and go with that. There are other relaxation metals. Why was gadolinium chosen? Great question. That's probably more of a question for the pharmaceutical companies. It has 7 unpaired electrons and it does a very good job causing the image to appear bright when it's present. So I think it had to do with the quality of the image that resulted from it.
Yeah, Matt, we should probably move on to Ben.
Yep.
Thank you. And you raised some important questions and gave us some important answers as well. Now, Ben, why don't you tell us about how biparametric non-contrast MRIs have been adopted at the University of Michigan?
Sure. So I'm going to share some slides if that's okay. And really the story about this revolves a lot around Dr. Davenport's work. So this is a nice bridge from that. Can everyone see the slides, and does it come up as presenter mode or just the full slide?
Full slide looks great.
Awesome. Okay, so just a little bit of background about this story. So it all starts with my dad, and I think like many of you on this Zoom today, you know, my dad actually has low-risk prostate cancer and he's on active surveillance. And a few years ago, he got a prostate MRI and he came back home furious and livid. And he told me that he got a contrast injection and it slipped out of his vein and he got this big bruise on his arm and it was painful. And, you know, he didn't have a pleasant experience with the tech. And, you know, he came home furious and he said, you know, this whole active surveillance thing, I hate this. I may as well just get my prostate out. I don't want to really do this ever again. And, you know, as a urology trainee, I felt like I'd really failed him. You know, someone who's training my whole life to take good care of men with prostate cancer and convince them that active surveillance is a good pathway if they're a candidate. And I felt terrible about this. And, you know, this is not just a story about my dad, but this is data from Europe showing that actually 1 in 10 men on active surveillance end up converting to treatment despite no change in their biopsy score or disease. And there's a lot of theories that a lot of people just convert to treatment because they've had enough with the whole active surveillance process and protocol. And really, that's a big failure from all of our end. So really, you know, through my dad's experience, I became really interested in prostate MRI. I'm not an expert in prostate MRI by any means compared to our first 2 guest speakers, but this is where I first got interested in it. And I just kind of wanted to share a little bit about what I've learned and tell you how University of Michigan has been adopting this over the last couple of months or so. So like our first two speakers were talking about, there's three phases traditionally for this multiparametric MRI. A biparametric just gets rid of the thing in the right-hand column, the vascularity. So biparametric MRI has a T2 phase and a DWI phase. Multiparametric MRI has this contrast phase. And so we're talking about this and getting rid of it. And this is a little bit esoteric, maybe for this discussion group, but in general, when we talk about PI-RADS scores, it goes from 1 to 5, 5 being highly suggestive of cancer, 1 being like a very normal prostate. And notice in the red box here that for the most part, contrast is used to differentiate between scores 3 and 4. That's the primary purpose traditionally, to help be like a tiebreaker, if you will, between 3 and 4. And the question is, well, that's nice, but clinically, in an everyday urology practice in the office, does that actually matter whether a patient has a 3 or 4, and how much more useful is contrast in that instance? I don't know if you've heard of music, but this is a really big QI collaboration in the whole state of Michigan that really closely tracks prostate cancer outcomes and practice patterns. And this looked at all men who had PI-RADS 3 lesions to say, what happened to them? Did they end up getting a biopsy, or did some urologists say no biopsy? Because the 3 score is kind of in between. And what this graph shows is over time, most men with a PI-RADS 3 score actually went on to get a biopsy, proving the point that differentiating between a 3 and a 4 isn't so helpful, really, because they're treated the same in practice in an everyday urology office. Both men end up getting biopsies. And so, the question is, if patients are recommended to get a biopsy, regardless if they have a 3 or 4, and when we do specific fusion technology to do a transperineal biopsy or a transrectal biopsy, if that doesn't require contrast, and if our guidelines typically recommend that patients get serial or confirmatory biopsies, even regardless of their PI-RADS score, do we actually need contrast in an everyday setting? And so this was our initial thought process, and it coincided really nicely with this ongoing PRIME trial. And we just heard about all the details and the results of that. I'll say that we started this project when we knew the PRIME trial was going on, and very conveniently, they published it earlier this fall to help validate our work and to make sure that what we were doing was certainly scientifically sound, because this study was really well done and had an appropriate protocol and had a lot of patients to help power their studies. And you see, just like we've talked about today, ultimately biparametric and multiparametric MRI are basically very diagnostically similar. I'll say from our end, one aspect of the research that we have contributed to is that biparametric MRIs are much cheaper compared to multiparametric MRIs. Now, if you have Medicare insurance, the out-of-pocket costs to you don't vary too much. It's cheaper by $10 to $30. But if you have commercial insurance, this could save some men upwards of $500 per scan and really lead to cost savings for the patients and the healthcare system. So in summary, just to kind of summarize big picture everything with the biparametric MRI, it can reduce scan time by 30 minutes. It lowers out-of-pocket costs. Patients avoid IVs and avoid potential risks of contrast exposure. And it can help the healthcare system by reducing staffing needs and material costs. Whereas really the only negative trade-offs to consider are some uncertainty between PI-RADS 3 and 4. It cannot be as accurate for patients with hip prostheses or ones who've had focal therapy or cryotherapy in the past. So, really it all seems promising, but the uptake of this in the US is still low and rare. So this is where the University of Michigan comes in. I went to Todd Morgan, who's a urologist in our department, one of the leaders of prostate cancer in this country, and Dr. Davenport, who really is one of the best leaders of prostate imaging in this country as well. And I said, hey, I've been reading about this. I don't know that much about this, but they're doing it in Europe, and I think we should make this a thing in the US. Could we trial this at the University of Michigan? And this is why I love this place, because they said, hey, let's do it. Why not? Let's give it a shot in a well-controlled environment. and study the results, and based on the results, we'll provide some sort of commentary. So our pilot trial here was, could we pilot the biparametric at U of M? Our goal was to just develop a small cohort of patients to offer the biparametric MRI and to look for outcomes. And the outcomes, it wasn't a study like we heard about with the PRIME trial, wasn't looking at, biopsy outcomes. We didn't have all the resources to really do this in a, scientific question way. But we wanted to see if a radiologist looked at this, how many would say, yeah, this report is adequate, or no, this biparametric MRI did not lead to an adequate interpretation. You need to restart the imaging and do it all over again. So here was our protocol. We tried to pick a really safe inclusion criteria, meaning men on active surveillance who have already had an MRI in the past before, so something to compare to, and guys who did not have focal therapy or any hip prostheses, and then images that were obtained in our system. And if that was the case, then we would order them a biparametric MRI for their next surveillance scan. And the way we implemented this is, when you go to the doctors and the doctors just focused on the computer the whole time, we updated the order set. And we started this trial in about January of 2024. And just a few months later, we actually were able to get scans on 72 patients on active surveillance. I'll share a little bit of the data. In general, the median age was 69, and this is a cohort that maybe many of you can relate to. Majority of the patients had grade group 1 disease, 3+3 disease. Some patients had 3+4 disease, grade group 2 disease, and the median PSA was about 6.7. So here you can see the changes to the PI-RADS scores between the two modalities. But the most important thing I want to direct your attention to is that really only 3 out of 72 of the MRIs were evaluated to be inadequate by our radiology department. And that was all 3 patients. They had hip prostheses, and so they were supposed to be excluded from the study in the first place anyway. And so, said in other terms, 96% of these MRIs were reported to be adequate studies by our radiology department, which we found to be a huge success. So we reviewed these results with our oncology department at the University of Michigan, and we had talked about this closely. And based on these results, we actually decided to evolve this from a pilot trial to expand this to all patients on active surveillance, who would end up getting serial MRIs in their lifetime and multiple MRIs. And as of April, so last spring of 2025, we had about 200 men get these studies, and certainly much more at this point in time. I will just show one graph to put into a different way. So this is some updated data from 200 of our patients. And on the left-hand column would be patients' initial MRI, multiparametric MRI, and on the right hand would be their subsequent biparametric MRI. And if you follow lines that go from one row to the next, that's trying to symbolize how much their scores changed. And really just realize that there aren't that many lines that change from one row to the next, signaling, again, for the most part, the scores stay the same on the subsequent scan, possibly signaling that the diagnostic quality is very similar compared to the original multiparametric MRIs. So it's been a really exciting project, and I just kind of wanted to highlight what we're going to do with this next. And one is we've talked a lot about the potential benefits for patient experience, but I'm really interested in actually measuring the patient experience. And I can see that a lot of you are all very passionate about this, but I'd love to actually learn from patients and say, yes, I can tell it's shorter. This has changed my perspective of active surveillance. I'm more interested in active surveillance, or maybe not. The second is, we need to continue to measure our clinical outcomes and make sure that patients truly are having similar clinical outcomes based on this new imaging modality. And finally, it's been a huge success at the University of Michigan, but there's still way more space to grow. And we're hoping to partner with some of our nearby urologists in the state of Michigan to see if we can expand this. So in summary, there's now level 1 evidence from the PRIME trial that demonstrates that biparametric MRI is not inferior to multiparametric. I think this is an opportunity to significantly improve the patient experience with active surveillance. And I hope this presentation today shows that this pilot trial was feasible at the University of Michigan, there's no reason it can't be feasible elsewhere in the country. And finally, a huge thank you to Dr. Morgan and Dr. Davenport. This project started almost 2 years ago, us just having a casual conversation about prostate MRI, and they gave it the green light. They pushed us forward, and none of this work would have been possible without them. So they really deserve a huge amount of credit for this lift. So thanks to them.
Oh, Ben, thank you. What we'll do next is question and answer. I have a few questions, and then Jeff and David will switch around. But Ben, did I miss it? You didn't tell us what happened to your dad. Is he still on AS? And if he is, why isn't he here today?
That is such a good question. He's still on active surveillance. He's doing great. He actually has not had a biparametric MRI yet. He lives in Washington, D.C. But his urologist and I have talked about this, and maybe for his next scan he will. And I'm sorry he's not here today. I think my mom dragged him away to do something else.
Well, he's always welcome to our meetings. And so everybody knows, next month we're going to have a similar panel on not biparametric. I'm getting transrectal versus transperineal from the people who've done the major studies on that. So tell your dad to come. He'll always be welcome. But one of the things that came up was very few American patients, it seems, have these MRIs compared to UK. And I wonder if the panelists can talk about the experiences from their own countries. Why is the UK so different from the US, and why is the US so different from the UK? It seems like the system isn't working here. Matt or Ben?
Yeah, you've asked a question that would take the rest of the time to talk about, Howard. This is a 40-minute question. There's huge structural differences in how care is delivered in the UK versus the US. A major difference has to do with in the US, we're primarily a fee-for-service type of healthcare environment, and the UK, it doesn't have the same thing. So I'll let Veeru comment on how it's done in the UK, but in the States, the fee-for-service model creates incentives that do not align always with what patients want most, which is to have a healthy life, a happy life, and a long positive health span. In the US, we tend to have a reactive healthcare system that's not based on prevention, it's based on reacting to a diagnosis once it's occurred. And doing more generates more wealth for pharmaceutical companies, for doctors, for health systems, as opposed to making people healthy longer. So I'd say that's the biggest reason why.
Yeah, well, before I turn it over to Veeru, I wanted to mention that the ASPI group has had actually an ongoing relationship with music, and because music has done so much with active surveillance, but music sort of disproves the rule or whatever, contradicts the rule in terms of active surveillance. The uptake in Michigan is more like that in Britain. But let me ask you a Michigan question. In terms of uptake of biparametric and just of MRIs in Michigan, is it anything special the way the AS uptake is?
Yeah, actually, in Michigan, this is something we're pretty proud of. In the state of Michigan, what Howard alluded to is we have a statewide quality collaborative called Music. I think about 90% of all the urology practices across the whole state participate in it, and they receive incentives to participate and drive towards better outcomes. And that is a major reason why active surveillance uptake in appropriately selected patients is very high in Michigan. I think it's around 90% right now of people who are eligible for active surveillance end up moving in that direction and getting active surveillance as their primary or first initial management strategy. Ben, do you want to add to that?
Yeah, I mean, I would just say, maybe we're a little bit behind on the biparametric 8 ball, but this is all fairly new. And, Multiparametric really came into the scene in 2017. That's just 8 years ago. And I think with Veeru's article and JAMA, I think things will really change rapidly over the next 2 or 3 years. It's no challenge for urologists to order this. I mean, for us, it's if our patients are happier and we're getting good radiology reports, it's easy for us. I think it's just about education and training, and probably over the next 2 years, it'll become more popular and really become maybe standard. I've already seen the new version of the NCCN guidelines are which help direct us for management really internationally. And they've already started to mention biparametric MRI, probably all thanks to Veeru's work. So I think things will just change and soon. This is all new for us.
Yeah, Veeru, anything you want to add on the US versus UK?
Yeah, look, first of all, it's great to be in the session, and thanks to Ben and Matthew for your talks. I always learn something in every talk, and I definitely learned something from your expertise. Now, on to the question. So, yeah, I think it's very much due to the way that the services are delivered. So in the UK, I would say 95% of patients with suspected prostate cancer are diagnosed through the NHS, which is a free approach for any patient who sees their local community doctor and is referred to the hospital after a raised PSA or abnormal digital rectal exam. And because of that pathway, there is a timeline. So from the moment that the patient is referred to the hospital, there is a 31-day timeline from referral to diagnosis. And if the patient is not diagnosed within 31 days, the hospital gets fined. If they're not treated, i.e. surgery or hormone therapy with view for radiotherapy or focal therapy within 62 days, the hospital gets another fine. So because of that timeline, it means that the hospitals are set up to deliver the diagnostic services quite quickly. Otherwise, they're going to get lots of fines. So that's why many more people probably get an MRI in the UK setting than many other settings.
Gotcha. Jeff, why don't you throw in a couple of questions, and then David?
Sure. Thank you, Howard. Thank you to the doctors, and thank you to our wonderful audience here today. First question, doctors, I have it from Todd Whitgore. Todd asked, can the same MRI machine do both bi and multiparametric, or do you need separate machines?
Yeah, great question and an easy answer. It's the same machine, the same protocol. Everything happens exactly the same. You literally just don't do the post-contrast imaging. That's it. Everything else is the same. Same machine, same protocol. You just don't put the catheter in, you don't give the contrast, and you don't take the picture after the contrast is given.
Other doctors care to chime in?
Yeah, exactly as Matthew has said.
Okay.
Same scan. Actually, that's one of the most common questions I've received when I've spoken to patient groups. So, yeah, same scanner. Anywhere that's currently doing the multi-parametric MRI can do the bi.
Doctors Pockros and Davenport, any comment on that?
I agree. I guess I'm trying to think of potential exceptions. Let's say someone's using really outdated equipment that's really not very good, and let's say their diffusion weighted imaging is poor quality because they don't have this is a technical word, the gradient strength to get good images. This would become maybe an older machine, 10 or 15 years old. That would make me more uncomfortable in that case because sometimes contrast is used as a backup sequence. But generally speaking, if you're using a modern scanner in the modern age, yeah, I don't see a reason why you couldn't do same scanner, same protocol.
Okay, and Dr. Davenport, do you care to expand on your answer about prostate cancers that are not visible on MRI? You gave an answer there. I thought that was feasible. Could you talk to us a little bit about that for our audience?
Absolutely. So one of the quirks about MRI is that it does not do a good job detecting grade group 1, also called Gleason 6, prostate cancer. It does not really see it that well. And that's actually a bonus. It's a feature of MRI because in general, we don't want to detect lower risk cancer as a general rule. There are a small number of cancers that are grade group 2 or higher, also called Gleason 7 or higher cancers, that are not seen on MRI. And depending on which study you look at, what the inclusion criteria of the patients signing up for it, what their pre-test probability of disease is, it's usually single percentage point worth of patients. So maybe 3%, 5%, 7%, something like that of patients you might have a Gleason 7 or higher cancer that's not identified by MRI. We express that risk as a negative predictive value. So if you get an MRI and you're an average risk patient, the negative predictive value of an MRI, which means a negative is a negative, it's truly negative, is very high. It's in the mid 90s%, which means a small number of cancers that are Gleason 7 or higher are not seen. Veeru, do you want to weigh in on that?
Yeah, I agree completely with Matthew. And the one thing I'd add would be we believe that the prognosis of the cancer is in part driven by the visibility of the cancer on the MRI. So if you have a visible cancer on the MRI, those patients are likely to do worse. And we've seen that from series where patients have visible lesions and go on to have surgery. They have poorer survival outcomes. If you have a cancer that's not visible, but say it's a grade group 2 or higher, in our series and in others, they actually do better than those that are visible. So we would argue that even if you miss a little bit, whether it's 5% or something around that region of grade group 2 or higher cancer on the MRI, those cancers probably behave in a way that it may be okay to miss them. But I don't think that's necessarily widely accepted around the world, but that's what we believe from the work that we've done.
Yeah, I'd like to throw in something there too. If you go to aspatients.org, we did a program earlier this year focused on the invisible men. And we had Dr. Mark Emberton as our speaker. We only get the best speakers, folks. You may not know it, but it's true. But Jeff, I think it's time for David to weigh.
Oh, yes, absolutely. David, fire away.
For all of you, the question is prepping the patient to do the MRI. I've come across research and experience that some patients are recommended to do an enema the night before, an enema before the event, drink clear liquid diets. Some radiologists will use glucogen to slow down the bowel movement. The whole idea is to avoid that fart syndrome where you might get a bad imaging or bowel movement that can, blur the imaging during the process. So what would you all recommend as the optimal approach for those who are proactive and really want to get the highest quality image? What can we do as patients?
That's a great question. I say the most common reason we see images that are not good enough quality on the diffusion weighted sequence, which is really important if we subtract the contrast. The most common reason we see problems is because of rectal gas. So we use it sounds really simple, but using the restroom right before you get on the scanner is really important to get that gas out of the rectum. That's probably the number one most important thing you can do is get that gas out of the rectum. A lot of patients will say that maybe they're laying on the scanner and they feel the urge to, sorry again for the crude language, they feel they need to fart and they're nervous to do it because it's a social setting and they're embarrassing to do it. Get the gas out of the rectum. You want to get it out. Now, to your point, David, some sites will actually recommend doing things like enemas or giving drugs like glucagon to try and promote that. I think this gets into the issue that Veeru was mentioning earlier, which is there's kind of a trade-off between access and having people want to sign up to do this and also trying to maximize the imaging quality. So if you took the average person and said, we're going to give you multiple enemas and give you a drug and have put in a needle into you to inject that drug and have a nurse handy to handle it, it ends up being too much for a lot of people. And they say, you know what, maybe I'll just skip that. So if you were someone who said, look, I'm willing to do the maximum, I want the maximum to be done, I think things like having a clear liquid diet for a few days before, I think making sure to use the restroom in advance. If you chose to do a suppository in advance, you could choose to do that. I would say it's not necessary. At Michigan, we don't do any of those adjunctive measures, and our image quality is excellent, and our performance data is also excellent. So I would put those as optional things, not necessary. And Veeru, I don't remember in the PRIME trial, but I don't think there was a requirement for those adjunctive measures. Is that correct?
Correct. Yeah, we didn't mandate anything in particular. We just asked centers to use their usual protocol.
Okay.
And yeah, incidentally, in the UK, for example, at our centre, we would not ask patients to have enemas beforehand. Our pre-procedural preparation is relatively minimalistic. Occasionally, you do see some images with poor, diffusion artifacts, which is because of the rectal gas or other things like hip replacements. Interestingly, in PRIME, we wanted to allow those patients to be included in the study. So we didn't exclude patients with hip prostheses or any other reasons for artifacts in the scans. And what we found was in our cohort of 500 patients, it was uncommon for the biparametric MRI to be of poor quality and the contrast to save it. Equally, this is a 500 patient cohort, so we accept our radiologists are usually very pro contrast. So for us to see the results, it was a bit not necessarily surprising for us, but it was certainly something that we didn't necessarily think would be so clear in its outcome. And so, I would argue, based on the review of the scans in PRIME, certainly, you can get really good diffusion images now in some of these patients with, say, hip prostheses or other things, and we didn't really find the contrast helped that situation, but that's just our anecdotal comment from our trial review. But in the broader clinical practice across more patients, you might notice it makes more of a difference.
Ben, do you mind if I ask you, like in your experience, on the clinical side, seeing patients come through clinic with scans that were done, maybe not at our center where we're comfortable with it, to what how often do you find images that are not that diagnostic on your end when you're trying to manage them?
Well, they can be really variable. And so I'd say in general, just the way that we like to do it, if patients have imaging from outside centers, we like to re-review it with you to make sure it's the same. When you say non-diagnostic, you mean like a radiologist saying too much rectal gas or hip? I actually have not seen that frequently. Usually there'll be some sort of report, but the question is whether that report's accurate. Right.
Okay, thank you. A couple more questions if we have time. One is, how is it that gadolinium goes to one area versus another? What is it about that rare earth metal that lights up one area versus another? Could you answer that, please?
Yeah, absolutely. So all of the gadolinium-based contrast agents are administered into the bloodstream. And so functionally what they're doing is they're showing you vascularity. So they show something that has more vascularity than something else. An example might be if something's inflamed, the vessels would be dilated or more robust, and so that would be brighter than something not inflamed. Or if you have something that's a solid tumor that has extra blood vessels inside of it because the tumor is promoting the development of blood vessels inside of it, it would be extra bright compared to tissue that's nearby. So essentially, it's a measure of perfusion.
Okay, thank you. And are the MRIs better for the transitional zone versus the peripheral zone? Is there one versus the other in terms of quality? Or are all the areas of the prostate treated equally?
Yep. When we interpret MRIs, we use a PIRADS system, the Prostate Imaging Reporting and Data System, PIRADS. I think Ben showed an example of what that is, that 5-point scale. When we're applying PIRADS, the rules for PIRADS differ depending on whether you're interpreting something in the peripheral zone or the transition zone. There's different rules. The radiologist knows those rules and applies them. Importantly, contrast enhancement is of almost, even among people who favor contrast or who like contrast, they would even acknowledge that in the transition zone, there's almost no value at all because all BPH pretty much enhances. BPH being those benign nodules that happen in the transition zone, and almost all of them enhance. So it really doesn't help us that much in the transition zone. There are some rare examples where contrast can be helpful in the transition zone. So for example, determining that something's actually an abscess and not a tumor. in some patients where they have a risk of abscess, for example, there could be some value to that. And one really important thing that's been kind of alluded to, but I'm not sure anyone said it really out loud, is that if someone's previously had treatment, let's say you've had a prostatectomy or you've had an ablation, those patients are not what we're talking about here. So people who've had prior therapy or even radiation therapy, prior therapy, for those patients, I would continue to recommend giving contrast because that's the primary way we actually make a diagnosis of recurrent disease after treatment with radiation or surgery or in some cases ablation. So these are in patients who don't yet have treatment in the prostate.
Matt, are there any other groups where you would recommend that they continue with gadolinium?
My perspective is if you've previously had treatment to the prostate, yes. If you have very little confidence in the radiology group, then maybe. But otherwise, there's probably not a reason to do it.
Well, we're in a dilemma in deciding who not to have confidence in.
Yeah.
David, do you have another question or
Well,
can I?
exactly related to that, is there some way a patient can discreetly and delicately, without harming the ego of somebody, how good are your radiologists? I mean,
Yeah.
How experienced are they in the prostate area versus, like you said, maybe a generalist?
Mhm.
How do we find out as someone who wants to, make the best use of our time and get the best imaging?
Yeah. One way to do it that might be easy is, Veeru's study did include places all across the world. And if there's a site that you're considering going to that's on the list of participants in the PRIME trial, I mean, obviously that would be a great choice. Let's say you look at that list and say, gee, all those places are pretty far away. I'm not sure I can go to one of those. You could always just send an email to me or Ben. We could tell you, if there's a spot nearby, that's probably a good place. The key questions to ask are the people reading your prostate MRI specialists, meaning that they have a specific fellowship training to interpret, MRI of the prostate. And usually that fellowship training will be called abdominal radiology fellowship. And if they
Okay.
have that, you can have some confidence that they're doing a good job.
That was really helpful. Thank you.
Howard, I had a
Yeah.
question. Can I shoot in here?
Well,
Yeah.
you're going out of turn, Jeff. I have a
Oh.
question first.
Oh, go for it. You're older.
Something that hasn't been mentioned, but I know is important to up to 15% of us, is the impact this can have on patients who get claustrophobic. I wonder if you could comment on it. I can tell you personally, I avoided MRI for 8 years until I saw what was being done at Michigan. And I twisted my doctor's arm and I had biparametric and it was a breeze. I didn't freak out at all. So I don't know if some switch went off in my brain but how does this help with
Mhm.
claustrophobia? Anybody?
Mhm. Ben, you want to weigh in?
I mean, I would hope it really helps. It's one of the things I'm hoping to measure in a future study, but if the original scan takes up to 45 minutes and this one might take 20 minutes, suddenly it becomes more feasible for men. I can tell you in clinic, I hear all the time how uncomfortable it is, not just claustrophobia, but if you have a bad back, right, laying flat on your back on the scanner can be really painful. And so my hope is that this is a much better experience.
Yeah. So Jeff, go ahead.
Thank you. Thank you, Howard and Dr. Pockros. I wanted to trail off that and then ask a question. Of course, when I've gone through MRIs, as we get older, some of us get arthritis and it's kind of tough to be in this tube and they tell you don't move around. So, I think some thought could go into that by not only the manufacturers of the MRI machines, but also the practitioners and the staff. I mean, a pad here, a warming pad there, I don't know. It might mess up the whole mechanism, but pain is a problem. The question I had, Howard, thank you, is what don't we know about gadolinium? Are there other substances that are, I think the word contraindicative? Diet, for example, are there other things that the gadolinium in my diet, perhaps, and some of the medicines I'm taking might throw things off.
Mm-hmm. Yeah, to my knowledge, there's nothing that you would be taking as part of your normal diet that are going to interfere with our ability to interpret a prostate MRI. So no concern there. If you do live in an area that, is downstream of a big medical complex, you probably do have some gadolinium, a very tiny, tiny, tiny amount of gadolinium that's in your water supply. You probably are consuming it, but it's not going to have any impact at all, on the image quality. It's in too small of doses and it wouldn't show up. I don't think it's a major consideration. Is
Okay,
that your question?
yeah, doctors, I was thinking, is the gadolinium going to do any unknown harm to me because I have something in my body, not just in the environment that I'm in?
Mhm. I mean, all I can say is that, gadolinium-based contrast media if you compare them to other, we can call it a drug, compare them to other drugs, whether you're getting penicillin or you're getting Tylenol or you're getting aspirin or you're getting an antibiotic. If you look at gadolinium's safety profile, it's pretty exceptionally good, actually. I mean, everything that we take and put inside our body has some risk, both known risks and unknown risks. I say as a general statement, it's a pretty safe drug when we compare it to other types of drugs.
Okay, thank you.
Mm-hmm.
Yeah,
I
David?
think it is worth kind of emphasizing that point because, like, I don't want us to come off as alarmists that gadolinium is this extremely toxic, substance that we've been giving to men. I think there are a lot of potential benefits with biparametric MRI, and withering away a substance is always a good benefit. Anytime in medicine we can take away a medication or any exposure to a patient, that's usually a win. But I don't want, people to feel terribly concerned that anytime they get gadolinium, they're going to have a serious detrimental effect to their long-term health. Because I'm not sure that quite hits the point of this project either.
Yeah. If I
Can I ask Matthew a question?
Yeah.
So, in our active surveillance cohorts now,
You should introduce your friend.
yeah, this is my daughter, Nandini.
Well, welcome.
She's just wandering about home. She's joining the webinar.
If
So
she has any questions, she should feel free to ask.
Yeah. So yeah, many of our active surveillance cohorts, we have patients who have had MRIs for over 10 years now, and typically we do the baseline one at 1 year and then every other year. If you're having 6 or 7 scans, and we know there is that retention that you described, although there's no known bad effect, is there any data on if you have lots of scans and lots of retention, whether there is anything that might cause harm?
Yep. Great. That's a great question. I'm going to answer it in 2 parts. The first is that there's 2 major classes of gadolinium contrast. This is going to be a little bit wonky, and I apologize. Some of them are called linear agents, and conceptually, you can think of it like this. You have gadolinium sitting here, and there's a chain that's attached to it. So it's like a line. It's a linear agent. The linear agents are more able to break apart from the chelate because there's only like one little connection over here. There's another group of contrast media called macrocyclic. In that case, you have the gadolinium ion in the middle, and you have a cage of ions that surrounds it. If you think about those 2 different kinds of gadolinium-based contrast media, the linear ones have about an order of magnitude more retention than the macrocyclic ones. In addition, the macrocyclic ones probably retain in a different way. Oftentimes, the macrocyclic ones retain in your body still bound to the chelate, whereas the linear ones may be more likely to bind with things inside your body, different kinds of ions inside your body. So why am I mentioning that? In patients who get repeated scans in which contrast is necessary, a great example of this is screening breast MRI in patients who are high risk for breast cancer. We cannot remove contrast in that context because it's necessary to make the diagnosis. Or let's say someone who's a child who has inflammatory bowel disease, and we have to do multiple MRIs of them, every 6 or 12 months or whatever to monitor their disease. We can't take away the contrast because it's viewed to be important to make those diagnoses. So in those patient populations, we aim to give them always a macrocyclic contrast agent to lower that theoretical risk, and we do not tend to give them linear agents. All that being said, so far, to my knowledge, there is no linkage between repeated scans, whether it's linear or macrocyclic, and a health consequence for patients. But I think this falls into the general concept. I think Ben alluded to it. We call it ALARA, as low as reasonably acceptable. So in general, we want to minimize even theoretical risks. So in a patient population getting repeated scans on active surveillance, or if we're looking for breast cancer or inflammatory bowel disease or whatever, we'll tend to give them a macrocyclic agent just in case. But to my knowledge, there's no studies that have confirmed an association between I got 7 of these and now I've had more retention, so it's causing more harm. What we do know, Veeru, is that as you get more and more agents over time, the amount of retention goes up. We also know that if you stop getting the agent, let's say you take a vacation from getting MRIs, then the retention tends to go down over time and eventually stops being visible. So that's the best of what we know so far.
If
I
I
want
could,
to throw something in here on resources. And I know our MBAs are concerned about costs, that sort of thing. But, we're in a period where there's an increasing number of men being diagnosed with prostate cancer. And I'm wondering about capacity of MRIs. Is there enough capacity in, say, US or UK to serve the men that are out there who need to be served?
Great question. I'll respond on behalf of the US. This may be new information to some of the people on the call, but radiologists are in short supply right now in the US, pretty significant short supply, and it's predicted to continue to get worse. And what that is there's a pretty strong demand for medical imaging and not enough radiologists to do the reads, and also not enough equipment and technologists, MRI technologists, to perform the scans. So most places, if you go to them and say, I'd like to get an MRI, they'll tell you, sure, we've got a 4-week or a 5-week backlog. So you're going to have to wait a little bit, but yeah, we can get it done. I think from a prostate diagnosis standpoint, because they're not emergencies, I think there is capacity to do what we need to do in the States right now. And I think this conversion to biparametric is going to make a huge improvement in access, because you're going to probably cut the number of minutes required per scan significantly, which means that more people can be scanned for the same number of scanners. Veeru, what's it like in the UK from a capacity standpoint?
Yeah, I would say it's decent, because multiparametric MRI has been standard of care for over 6 years. We are delivering these scans. In 2019, I gave you figures that about 60% of men are getting it. That's increased to about 3/4 now. There will be some men for whom an MRI may not be necessary at all, of patients who may be more elderly or may not be eligible for treatment. So, we're getting better. I would say, though, we are all going to be faced with a challenge in the next 20 years, because we know that, especially from things like the Lancet Global Commission, the number of prostate cancer cases are going to double in the next 20 years. So there's already a problem, I would say, with capacity and access, and that's going to get worse. So things like biparametric MRI and streamlining our diagnostic tests are the only way we're going to be able to meet the growing demand in the next 20 years.
Yeah, David, did you have some question?
Howard, could I
Yeah.
jump in here real quick?
Yeah.
We received an email question Harley Myler, and what he asks is, what do you do when the state of your prostate suggests a biparametric MRI, but the clinicians won't hear it? How do you address that?
Ben, you want to take that one?
Well, I think like what we were talking about earlier is that a lot of this is still new. And so, we're all presenting and talking about biparametric MRI as an exciting option, but most importantly, your urologist and your radiologist needs to be comfortable with that. And so it may be too soon, depending on where you live or where you get your doctor, to ask for a biparametric MRI. I'm not sure if that's what the question's getting at, but I'd say, currently, you really have to do what your urologist is most comfortable with, because they're going to be the one quarterbacking your prostate cancer risk and care and next steps. And so It is always appropriate to bring new information to your doctor. I love when patients come in, hey, I read this article. Hey, I've been listening to this on the podcast. What do you think? Because I love to learn new things from patients, but you can't be surprised if your doctor's playing a little bit of catch up and saying, I haven't really heard about this. Let me get back to you. Let me dig into it and ask some friends, and then we can think about next steps.
I think there's cases, maybe not specifically this gentleman's, but cases where um, the patient is way up to speed on the current technology, and as you're pointing out, the urologist and or radiologist might not be. But then that raises the question where do you draw the line at the point where you say, well, I just need to go somewhere else because they're either not up to speed or they are completely unwilling to do your request.
Yeah, that's a very personal decision. That's a challenging decision. I'd say at this point in time, the importance of whether you get a multiparametric MRI or a biparametric MRI is a nice convenience and benefit, but I don't know if I'd instruct someone to find a new urologist just based on the availability of that imaging. We always tell patients you should always get a second opinion if you wish, but Dr. Davenport was talking about the radiologist shortage. From my perspective, I'll say there's a huge urologist shortage in the US as well. 60% of counties in the US don't have a practicing urologist. 1/3 of urologists right now are above the age of 65, so theoretically going to retire soon. And we know that we have a growing aging population who's really going to become in this
I'll be
prostate
honest.
cancer cohort. So from our end as well, there's a huge labor shortage. And if you have a urologist that you've been working with, who knows your data, who you trust and like, usually my recommendation is to stay plugged into their system. Although you can always get a second opinion if you live in a county that, there's multiple practitioners there.
Now, I know we're running up against the time the meeting is supposed to end, but typically for us, we drag on a little bit, and then it looked like Mark Lichty had a question. Mark?
I did. First, I wanted to thank all of you. I mentioned early on that all three doctors here are donating their time, and this has been excellent. And I wanted to thank you, Howard, for gathering this panel, outstanding panel. I continue to be I feel a little better about the gadolinium than I had at the beginning of this conference or this webinar. Although the fact that the gadolinium can stay in the brain for 9 years, a heavy metal in the brain for 9 years, still causes me some concern. Now, you outlined two different kinds of gadolinium, and the one was suggested for repeat MRIs. Now, because I have had multiple MRIs and years ago, I had much gadolinium before I was aware of it. I can't even remember the name of the gadolinium. What was the name of the gadolinium for the repeat MRIs? Because I'm thinking that's a gadolinium I should ask for if I have an MRI, whether it's, well, yes, I have had gadolinium in the past years ago. So I want to know what the name of that
Yep.
was.
Yes, I put in the chat the class of them, which is called macrocyclic. Those are the ones that are more
Cyclic.
stable.
Yeah.
Underneath that umbrella of macrocyclic, there's a whole bunch of different trade names that fit under it. They're including Dotaram, Gatavist, Viewway, which someone put into the chat, Clariscan. There's a whole variety of agents that are classed as macrocyclic. So one thing you could do is just ask when you're going to get your scan set, I'd like to please have a macrocyclic contrast agent if they decide to do that.
Excellent.
You were
Thank you.
hinting at, well, I just got an email also, and it's something that was on my list, which is the role AI is going to play. I was reading a study this week about AI improving the ability. Well, okay, there was a part of this research was looking at low dose gadolinium, and now they're talking about low dose with using AI or using AI itself to improve images. So where does AI fit into this discussion?
AI is going to fit in all over the place in radiology and probably other specialties too. With respect to your question, AI is already being used to accelerate image acquisition process. So the image will be better quality, obtained in less time, which is going to have some of these same advantages of doing a biparametric approach because you're going to be able to do a faster scan with better image quality in a shorter time slot, which is happening right now. We do it at Michigan. Another place AI is going to come in is for diagnosis. So an AI tool is going to look at the images and say, is the cancer present or absent, and help the radiologist make a decision about that. There are tools right now. One of them I can think of as FDA approved. There's not very much penetrance into the market right now with that tool. I mean, almost nobody is using it. A major reason why, like when we talked before about structural issues in the United States, is there's no reimbursement for it. So it's just pure cost to the system. And so there's no incentive for the practices to adopt it. I think the benefit of AI for diagnosis is going to be, it's going to raise the floor, which means you won't have as much heterogeneity of, some being bad quality interpretations and some being good quality. It's going to raise the floor so people in general are performing pretty much the same. And I think AI is also going to be used for actually creating radiology reports. So not only just interpreting things, but also plugging in maybe some clinical information with the imaging information and generating a report for a radiologist to then proofread.
In the radiology world, could AI do the first read?
Yes.
Can this make up for some of the manpower deficit?
Potentially, yes. So one parallel to this is in Europe. It's common for mammograms to be double read by 2 radiologists, and some recent landmark trials showed that if you substitute one of those 2 radiologists with an AI, you could end up getting at least as good of diagnosis with half the resource. In the United States, it's not common for you to have 2 radiologists interpreting a mammogram. So, and because the AI tools can't do independent interpretation without a doctor for a lot of regulatory and other reasons, the time savings is likely to be somewhat less. I think what's going to happen, though, is that for high volume practices where you're doing thousands of a particular kind of exam, AI will be used to screen out negatives and then only have the radiologist focus on things that may have positive findings in it.
Well, we've taken up a lot of your time. Let me ask David again. David, any final questions? Jeff?
I'm good.
Howard,
I'm just
Howard, do
very
you mind if I
delighted.
add one thing on that last point, which is probably quite relevant? So yeah, I do believe it's really worthwhile investing some time in researching the role of AI in this area. As Matthew highlighted, getting an expert radiologist with that experience is tough. They don't grow on trees. So my belief is with AI, if you have enough information, enough data quality, you can train an algorithm to be pretty good and raise a level across the board. You will still have, of course, your super expert radiologists who will always be better than an AI algorithm, but I think it will raise the average standards. So we are investigating this in a prospective clinical trial called Paradigm, which will be running over the next 3 years in a similar fashion to Prime. So hopefully that will be able to shed a bit of light on what the role of AI should be in the diagnostic setting and whether it should be used as an adjunct, at what stage it should be used. You mentioned things like the first review or in combination with a radiologist. We'll have a bit more data on that in due course.
Yeah, David, why don't you be the last one and we'll transition.
That's perfect. It's going to be very controversial. Do any of the doctors have experience with doing MRIs pre and post aqua ablation of the transitional zone of the prostate, finding that the aqua ablation hosed out cancer cells?
to do
Yeah, so there's
aquablation here?
actually there's actually a multi-center clinical trial being led by Procept, who make aquablation, for investigating its role in cancer treatment. So it's not necessarily, it's a different tradition to how we normally treat cancer. The way we normally treat cancer of the prostate with surgery is we remove the whole prostate and we try not to enter the cancer. This is a slightly different concept. So we'll have to await the results of the trials to know whether or not there is some value in doing it. But certainly one of the things it tries to minimize are the patient side effects. We know from radical prostatectomy, side effects can be quite bad. And for more minimally invasive treatment, side effects are better. So we'll have to await the results, but I can't really comment on right now whether it's a good treatment for cancer, but we're actually interested to join that study, which is a US-led study.
Thank you.
Well, I think that we should call it an end and thank our speakers. You guys did great. I hope the audience was satisfied and got most of their questions answered.